Right. Good evening. Is it afternoon? Can everyone hear me? So I can just give me a thumbs up. Okay, that's good. So we're already 2 minutes late. So this afternoon we have a great presentation from two great practitioners. So we're going to have Mr. Elroy Cameron and Mr. Glenn Hill Carolus. They are both CPUT alumni, graduated long time ago. Mr. Elroy Cameron is the clinical instructor here at CPUT. And then Mr. Glenn Hill Carolus is a part-time lecturer as well. And then is also a trainer in the International Center for Medical Training, which is ICMT. So they have a very great experience when it comes to Penthrox. They've used this medication, a lot of patients internationally. So they'll be sharing their experience with us and when and how and all the good things and the adverse effects about Penthrox. So I'll be muting myself now and then I'm going to give it to them. Thank you for joining us for tonight.
Hi, Jessica. You got your hand up. Is there a question or Jessica McCain?
Maybe she was just raising the hand to ask maybe we started or not. If she doesn't say anything, Mr. Cameron and Mr. Glenn can start.
All right. Good evening, everybody. This is Glenn Carolus speaking. Nice to be with you. I'm not sure if you can hear my volume, if my voice is coming through. Mr. Ati, can you just check with me if it's coming through on your side?
I can hear you clearly, sir. I can hear you clearly.
All right. Perfect. Mr. Cameron, is he in the room?
Yes. Good afternoon, everybody. I'm Mr. Elroy Cameron, and I'll be presenting with Mr. Carolus.
All right. So I think I will start off first. Sorry. Yes, Elroy. You wanted to say something?
No, I wanted to say you can continue, Mr. Carolus.
Thank you so much. All right, so just to kick off our presentation, once again, thank you everyone for joining and would like to welcome you all. All right, for this evening, we'll be looking at Penthrox as Mr. Ati has introduced. Just a quick question. Who has used Penthrox in the recent few months, year or so? Is anybody that has started off with Penthrox used it before? All right, thank you, Mr. Mark Pegio, all the way from Philippines. Thank you, sir. So we really got a big audience here from afar. Nice to see your name there. All right, okay, so let's move on. Yari, do I have control of this presentation of the slides?
That's correct, Mr. Carolus.
No, that seems
okay.
to.
No, you don't have. I'll do it for you.
Okay. All right. So just that little slide with the badge over there. So that's the World Rescue Challenge that has taken place in Cape Town in 2006, and we will get back to that little badge a little bit later. All right. So let's keep moving. All right. So just a disclaimer. We do not want you to change your practice in any way or anything that has been approved. So please proceed to work within your current organization's guidelines. And for our conflict of interest, we do not have any conflict to declare, and we do not have any affiliation with any specific organization, specifically in a commercial manner. All right. So for our overview, we'll be looking at sensing pain, pain assessment, as well as some pharmacological aspects, and we'll just review some cases. We'll just reflect on some cases that we have had to deal with in the past. So these cases might not be hectically, all blood, guts, and vomit, but we just want to take some salient aspects out of these cases and perhaps just share it with you. And hopefully it's a learning activity. And also, we would like your input. So please feel relaxed and engage with us. All right. Now, anybody in the audience, I'm not sure if you're able to disable your microphone. How do we assess pain? Is there anybody that'd like to just give a brief overview of how do you assess pain? How do you know that someone is in pain?
All right, can you hear me?
Yes, I can hear you.
Good evening, all. In my humble view, I will say, looking at a person's facial expression.
Okay, that's very valid. There was another hand there, Griffin Warris. Can you just unmute?
Good evening, everyone.
Hi, good evening. Oh, this is Samson. Sorry, so I got Griffin. Sorry, I apologize for that. Hi, good evening, Samson.
Good evening, sir. One of the things that I think that I have seen is maybe the patient will be guarding from pain, like trying to protect when you try to touch the patient.
Absolutely, that's fantastic. That's fantastic. Thank you so much for that. So, just moving on to our next slide. Mr. Elroy, okay, thank you for that. Anybody there would just like to give us an overview of this slide? I think this might take us about 2 hours just to run through that. But nonetheless, I've got a bit of a more simpler one that I would like to share with you, and that it won't take up all these elements, because remember how we sense pain and the entire pathway to getting to, hey, I've got pain in my finger or wherever that may be, is actually a very complex situation. So a more simple version of that is the keys. There's a couple of stages of this pain. So the first one that we're looking at is the transduction. Now, what that basically means is that painful stimulus, and literature refers to it as the noxious stimulus, gets changed into an electrical signal. All right. And then that follows up to the transmission. Transmission, that electrical signal then moves along all the various tracks, nerve tracks, until it reaches the brain. And perception, now that is the part when that nerve signal crosses over to the somatosensory cortex, and then we will know that we have pain. Modulation, that happens generally anywhere in all of these tracks, and modulation is basically the blunting of pain. So if you think about a highway, a lot of vehicles moving up and down, if there's a traffic cop that stands somewhere on the highway, slowing traffic down. So this is basically what modulation does. It slows these signals down and slows these activities. Now, this can happen, as I said, anywhere on these nerve tracks. So there you can just have a quick look at our noxious stimulant going through the transduction, through the transmission, up till the point of perception. All right. And this happens tremendously fast. It's not a very slow process. And you will know if someone knocks a hammer on your finger, you'll know immediately that there's pain. All right. But now here's the thing. We've probably heard a lot that pain is subjective. Anybody heard that statement before? Just a raise of hand quickly, someone? All right. Tennis. Could you share us what do you understand about that pain that is subjective? If you just quickly would like to unmute for us for 1 second. Is it perhaps in? I think I saw Sandile. Could you perhaps just share quickly with us? Okay, so not to delay the process. Now, the subjectivity of it is basically what it says. So I can have an injury, and another person next to me can have, let's say, pain. Sorry, not the injury, pain. And I might say this is excruciating pain. And for another person, it is almost like a little pinch. And this is where we as a practitioner, we can't gauge that level of pain between the two persons. Say, for instance, you're driving your vehicle at 120 kilometers per hour, and I drive at 119 kilometers per hour. Because the speed is so close to each other, it's somewhat a bit hard for us, especially for someone from the outside of your vehicle, to perceive exactly that speed. Well, obviously, there's calibration issues as well. But that's not really what we want to talk about. But this part of perception, this is what makes it subjective from our point of view. And if we look at two patients when they actually, I have a high pain and I have very, very little pain, right? So is there any questions up till this point? And if I'm moving too fast, please just let me know so we can slow down. Just raise your hand or put in the comments. Mr. John, you monitoring the comments there?
Yes, I'm monitoring the comments.
Okay, all right. Okay, so if this, I assume the pace is okay, it's not too fast. All right. So moving on to the next slide, this is Samson. Yes.
Okay, I don't know if maybe I understand it correctly on the subjected pain. Is it subjected to the object impact, or I don't know, I was just thinking the more the impact, the more the pain, or
okay. So basically what we're talking about is when we measure the pain, when we assess it. So I take, for example, I'm going to read a blood pressure. I put on the blood pressure cuff, I take the blood pressure, and I get a reading of 120 over 60, for instance. So I've got a concrete level or, a blood pressure. Let's say the next practitioner comes along, does the blood pressure, and, within a given variance, he might get 122 over 62. So it's fairly close, right? So we have an objective sense of what the person's blood pressure is, all right? But now when we look at this situation of pain, for instance, you get this new drink. It's a very strange color. I think it's a Fanta. It's a weird color. And then I believe there's a competition on it. And then they ask you, what flavor is it? So it might look like Coca-Cola, but it tastes like orange. Now, some people have their own perceptions about, about what it is. So it is how they perceive it. But we're not discounting that is real to that person. So for me, like I said, the pain is high. The person next to me, the same type of stimulus that person might get is a very low level of pain. So now we start thinking of things like pain thresholds. So some people can withstand a lot of pain and others don't. I hope I answer your question there, Mr. Sampson.
Yes, sir. Yes, sir.
Okay, thank you so much. Right, so moving on to our next slide over there. And that was a little badge that I put up. So in 2006, the World Rescue Challenge took place in Cape Town. That was in the parking area right behind the Tiger. It was still the Tygerberg campus. And we as students, I was a student that time. So we were assigned to be patients, all right. So it just happened that there was a bakkie or pickup that was on its side, and I was a patient inside. And it was an Australian team that came to my rescue at that moment. And this was the first time when I got introduced to Penthrox. Now, obviously, they didn't put in the medicine there. It was, I could not have had the medicine at that time. I would have clearly known about it. But at that point, I saw that this was the only team that, when they arrive at patient side, that they could, pick up some little whistle type of thing, that I've never seen before in my life. And it's actually a medication. So that was one of none of the South African teams had this thing. I think the closest would be someone bringing up a cylinder of Penthrox. That would have been the closest to, if we had to compare likewise items. Now, while I was sitting in that vehicle, they put up a safety device between myself and the roof, and they were going to cut the roof to extricate me, that was the exercise. But while I am seated there and someone is holding my C-spine, all my receptors were so alive when I started seeing this blade moving past my shoulder. And I could just think that, you know what, I'm going to lose an arm or something in this exercise. And even though that blade never touched me, I became acutely aware of everything that went around me. And this is also, I want to feed it back to the perception part. Like I said, it first starts off with transduction. Now, there's an actual pain, but there's also an aspect of it where you might have imminent pain. So I'm not getting really hit. So if I take a hammer and I just pretend I'm going to hit you, you really will become aware of the situation. And this is exactly what has taken place there. So moving on, a couple of years later, I found myself in a system and have been working quite a while with Penthrox for part of about, say, a decade. And that is just a little bit of a personal experience I wanted to share with you concerning this pain situation. Now, we are going to look at pain assessment. And I would like to ask anyone in the audience who's willing to share an experience or what do they do with regards to assessing pain. If you can, unmute your mic and just give us your input on this. Is there anybody that would like to share? Nobody?
Samson, I see your hand is still on, so you want to talk, Salam?
All right. Remember, I would like to have an interactive discussion. It's not just myself talking. I would like to get your aspect as well. I think we can learn a lot from that.
Let's give it to Sandile. I saw Sandile raise his hand there. Sandile, you can start talking.
All right. Okay. So perhaps there's a technical issue on that side. Nonetheless, let's look at some pain assessment, how we will go about this. Sorry, is there someone?
Yes, Sandile, can anybody hear me? Hello?
Hello, sir.
Yeah. I just wanted to comment a little bit with regards to the assessment of pain.
Okay.
First and a second. Yeah. It depends. It depends on what type of pain you are assessing it first, and then from there are tools that you to assess the pain. Also, usually depends on the age of the patient as well. With children, we usually use sort of like visual aid, and when we deal with adults, we use numerical aid to determine pain. Thank you.
Spot on. Thank you so much, Sandila. I really appreciate that. And as we move into our pain assessment, let's look at a couple of considerations or things that really impact our assessment. And you are absolutely right. Sandile mentioned age. And yes, come again. Okay. So Sandile mentioned that there's age. Age is one of them. And we also have cognitive ability. So there is a close link between them. They are linked and they can also be unlinked, if that makes sense. You can have a child that is 3 years old, for instance, and their cognitive ability we would expect to be at a 3-year-old level. But cognitive ability can also refer to, let's say they have some previous brain injury or some other sort of mental challenge, and that will also impact their cognitive ability. Now, you as a healthcare provider, now this is going to make your assessment quite a bit more challenging. Other things that we're looking at is injuries, illness, past medical history, physiological aspects, the person's emotion at that given point in time. We can even look at the environment or the situation.
Sorry, Mr. Glenn. Sorry,
Yes, sir.
people can people still please mute themselves? They can please mute. I see there's background there. I can hear.
Okay. Yeah. Thank you. Thank you. All right. So, and then there's also obviously social aspects that we can look at with regards to our pain assessment. So these are just a couple of things. There are numerous, but there are many more we can consider, and that will impact the patient at that given point in time. All right. So let's look at the following slide.
Samson, so you raised your hand. Do you have a question?
Oh, yes. I just got a thought when he was talking about the age and cognition. I once had a patient of about, I think she was about 2 to 3 years, and she was involved in an accident with her mom, and we found the child under seat, and apparently the concentration got we were actually concentrating on the mom because she was critical. And on our way close to hospital, we realized that the child condition was changing because she started to be pain. And one of the things someone explained that the children sometimes when they got serious pain, they don't react, they don't cry, they don't. I just want to get the clarity on that.
Sorry, Mr. Aure, I just had my line just broke up. Could you just maybe fill in there? I missed a part of that question.
Okay, what I'm saying is that we once got a patient of about the child of 2 to 3 years who was sent with her mom, and concentration was on the mother because she was critical. So closer to hospital, we realized that the patient, the young one, was changing condition because she started to be pale, only to find that she had a femur fracture, which was closed femur fracture. So someone explained that sometimes the children, they don't actually cry or react or do funny things when they have severe pain. The clarity, especially when you're talking about the age and cognition.
Yes. It's possible. Many people, I'm sure you've seen them as well in very difficult situations that it looks bad, but they're lying very patiently and quietly waiting. So remember, when you're also having a traumatic event of that nature, remember your body, and this is a part of those lot of chemicals and stuff that I haven't mentioned. A lot of these chemicals actually get released. Remember, you've heard of the flight and fight response. You get that, plus a whole bunch, a cascade of numerous releasing of chemicals, hormones, and you also get the blunting, as I mentioned earlier. So all of these factors play a role, and that's why the whole pain aspect is it's actually a very complex process. I mean, if you have time, just open up a textbook, and it will take you first to a chemistry class before you get to the anatomy and physiology class, just to understand all those things. And you will have that blunting for a moment. It is absolutely possible. I don't know if Elroy would like to mention anything here.
No, I'm okay.
Yeah, Mr. Carolus, and I just want to come in with a social cultural consideration when you assess pain. So some cultures, if you are a man, you don't have pain. Like they say, men don't cry. And in my experience, I've seen similar type of injuries where one person will say, fractured femur, now I will walk up, I will stand up and walk home, because in the culture is, if I show pain, it's weakness. Where in other cultures, the guy's finger might just be cut and he will be like, oh, I'm gonna die, I'm gonna do this, I've got so much pain. And that's where we as practitioners need to come in and look at also the social and culture aspect of assessing pain, because we can have some sort of idea if it's a fractured femur that must be very painful compared to a cut finger. And if this person is saying I don't have pain, that there comes in the perception again of what you perceive as pain and how you will see it in your culture and in your social aspects of things. And even your cognitive ability, if the person is under the influence of any substances or anything like that, he will be not able to tell exactly what type of pain he has, or he might exaggerate the pain. So there's all other factors that you need to take in consideration. Just wanted to say that.
All right. Thank you. Thank you so much for that. All right. So let's go on to our first pain score or our pain
So
assessment.
before you go there, Glenn,
Okay.
Mr. Glenn May had a hand as well.
All
I'm
right.
not sure
Sorry
if he
about that.
something
Yes.
or he
Go
wants
ahead.
to ask. Mr. Mayor, do you have a question?
No, thank you. I think Mr. Cameron actually covered the things that I wanted to actually speak about the cultures and about the different types of different countries, different people from various other Middle Eastern, Far Eastern countries, Asian countries, where they're not allowed to have pain, and it's not in their nature to ask for help or ask to be carried or ask for medication. So yeah, but thank you.
All right. Okay. So our first pain assessment tool, and it's one of many. It doesn't need to be the only one. And I think most will be actually very familiar with the OPQRSTA, where O is the onset, when did the pain start, provoke, P, what triggered it, what made the pain worse, quality, and we're looking at is this a burning pain, a crushing or a heavy pain, radiate, does the pain spread anywhere, or is it just localized to one area, and severity, is it a low pain or is it very, very bad? Timing, does the pain come and go, or is it is it a constant pain, and any factor that may alleviate the pain. So some people might say, you know what, if I keep my arm like this, then that helps a bit with the pain. And during your management, I like to chase that specific alleviating factor if it is present at given the situation, because that gives me a little bit of time to do some other things. Perhaps you sit with 3, 4, 5 patients, maybe more. So if an alleviating factor is there, do take profit on that factor. So if we just look at that severity, the score 1 to 10. Now this is that perceptive, that subjective point of the patient's point of view. I score this as a 7. And the patient next to me scores whatever the pain is, 5 perhaps. So this is one method of many, and I'm not saying this is the one that you should be using, but I think most of us will be familiar with this pain assessment tool. So our following pain assessment tool basically covers a lot of things. Now this is the Socrates, this is not the philosopher. But what this Socrates assessment adds is things like the site, and that's pretty much most of the what it adds, as opposed to the OPQRST. So very similar things that they do ask, just in a very different way. So I would say use what you're comfortable with, what you've been using for all this time. And whichever is makes sense to you. All right. So that just covers a couple of our pain scales. Now let's look at Wong-Baker pain rating scale, also a very common one. And this is pretty much where the severity comes in. Okay, this one rated from 0 to 10. Now, Wong-Baker, the faces are generally what they use for children. And then they have the numeric numbering system, the 1 till 10, which they generally use for adults. Now, a lot of studies has been done around this using different pain rating scales, comparing to each other. And this is that whole subjective thing that we're talking about. Now, obviously, one of our participants mentioned, you look at this, the facial expression, and there's number 10, the facial expression. So it's not very likely to be happy to have pain. All right. So at this point, let's move on to our pharmacological aspects. And here we will see, I see there's a hand.
Sorry, before we go further, I've also noticed, good evening.
Hi, good evening.
Good evening, sirs. Sorry. I just wanted to add also, when I do the pain assessment, I've noted or I've seen that adding a question into that is these days that helps me a lot is what have you taken to alleviate or help with the pain? Because I a lot of the times find that sometimes people also take pain medication before we even arrive or before they even call for help. That's just what I wanted to add.
That's pretty much that's correct. Because a pain medicine before you arrive, obviously maybe the pain was 5 and you arrive, now the pain is 3 because of that medication that was taken there. Thank you so much. So if you've not seen Penthrox, it's a very small little vial on the left of the screen, 3 milliliters. And this is our classic green whistle that they call it. And on top of the whistle, that little plastic casing, that is the charcoal cartridge that goes on top of it. Just to show you briefly what it looks like. I hope it's big enough for you to just have a look at that. So the first part that we will look at all our pharmacological aspects will be, we look at the pharmacological action, the indications, contraindications, dosage administration, and monitoring. And we'll just have a little, some information on this. So pharmacological actions, right? So now, when you take a pain medication, it does not take the pain away. It doesn't, remove it from your body. They work in very particular. Apologies, there was just a drop-in connection. So it makes them less responsive to excitation and pain. So when you inhale Penthrox, it can give you relief for up to 25 minutes. And you can add a second dose. The second dose will be the second vial. That will be the total of 6 vials. And that can give you up to 55 minutes when you inhale continuously on the yes, Mr. Alray.
Sorry, Mr. Glenn, just to interrupt you there. That's actually 6 moles and not 6 vials. You said
Yes,
the second dose. So if you give the second dose, it will be 6 moles in total.
Moles. And apologize.
Yeah.
All right. Sorry, I apologize for that. 6 moles and not 6 vials. So when you want to have an when you inhale on the inhaler intermittently, you take a puff and then, a break and then you take, that will actually increase your time of analgesia. So you'll have more time, hopefully to be perhaps not pain-free, but, where pain is more manageable and where the patient is more comfortable. Yes, Mr. Alroy.
Yeah, Glenn, just sorry to interject here with you. When you say pharmacological action, I mean, When if you take the one vial and if you're continuously using it, it will give you 20 to 25 minutes of pain relief.
Yes.
And obviously, if you use it intermittently, that 20, 25 minutes can move easily up to 30, 40 minutes, 50 minutes for one vial. That's if you use it intermittently. And the good thing of this one is when the patient is titrating his pain to effect. It's not us titrating the pain to effect, in the sense that the patient will inhale and take the pain medication as he needs it. But the moment when we administer, example, paracetamol IV, or we administer morphine or fentanyl or something like that, or ketamine, then we have the perception how much pain he have and how much we must give. But the patient himself, when he takes it, he control it himself.
Yes, no, that's absolutely right. So since this is a self-administered medication, the patient is in control of. Remember, the patient is able to feel the pain is getting worse now. Time to take, to inhale some of this, and rightfully so. The patient knows when he's got or she has some pain. So the next part that we were looking at is some indications. Now, in brief. Penthrox was developed, if you look at a historic point of view, partly to be an aesthetic, and then, out of it, they found that it's got also this wonderful properties that assist with the management of pain. So our indications, our next slide, please. So our indications then for us that we're using it pre-hospitally as predominantly for pain. So we're not going to use it as anything else, because remember, once you want an aesthetic dose, all right, then it becomes dangerous to the patient. So when we remain within the dosage of 3 mils or 6 mils, that's the maximum dosage you can give for any specific patient. That is when it is the safest to actually give to our patients. So we're looking at moderate or severe pain, traumatic pain, pain that's associated with trauma, but we can also have non-traumatic pain, such as in the case of cardiac-related pains, even in labor and obstetrics. So there are many cases that actually can benefit from Penthrox or methoxyflurane. So contraindications, in brief, if someone has pre-existing renal failure, diseases related or renal impairment, they cannot have it. Altered level of consciousness, well, we just mentioned now, the person needs to, self-inhale. It's an autonomous use. So if there's an altered level of consciousness, we will not also be able to give it. Here's our 6 mils within 24-hour period. We will not exceed that. Another aspect that we found in literature, and this really depends now how your organization writes up your contraindications, is 15 mils per week. All right. Known severity or adverse reaction, persons who may experience malignant hypothermia. Now, you're not going to know this if you just look at the patient. This is information that the patient needs to tell you. Listen, I had this event. So let me give you an example. Someone is allergic to a bee sting. I get a bee sting, then, this happens. Now, the same malignant hypothermia will be a very, significant event if that person, hopefully survive. That's, obviously I survive it. But malignant hypothermia is, and Penthrox is a trigger to this for those who are sensitive to getting malignant hypothermia. So part of the level of consciousness is your patient needs to be able to follow instructions. And you need to basically give him or her the instructions how to use this medication. If they're unable to follow their instructions, then you're unable to give this medicine because it's self-administered. And it really depends now your system where you're working at. Now, the tetracycline type of drugs, those type of antibiotics, since those medicines are quite nephrotoxic, now with methoxyflurane, they actually increase that toxicity. Now, again, it depends which side of the coin you're looking at, but I'm not putting this, we're not putting this as an absolute, but more or less, this is one of the significant ones that comes up a lot in literature, and also a lot in, whether you want to call it protocols or practice guidelines. That's one that also features quite often. Right. So let's just look at our pharmacological aspects in terms of dosage administration. We've mentioned it's a 3 milliliter vapor that you inhale. How we administer it? Well, it's a self-administered drug. We've mentioned this. One of the key points, yes, Mr. Elroy? Okay.
You can finish your statement first, and I'll come in there afterwards. I wanted to raise my hand, so I wanted to say something.
So one of the key aspects that we have for that I would like to emphasize is, now once you've given the medication, you need to monitor the patient, and specifically what we want is, and you know, there are so many different medications that you know, practitioners have all over the world, and what I've noticed now is the key classic ones that we always put in there is heart rate, respiratory, the saturation, blood pressure, GCS, or how it changes over, you know, the level of consciousness. And a very critical one, and this depends now what equipment you have available to you, is ETCO2, because this ties in very closely with that case of malignant hypothermia. Then the final part of the monitoring is having resuscitative equipment. So basically that should always be at hand, always be available, easy, accessible, should the need rise for that. Mr. Cameron?
Yeah, Mr. Listeners, I want to come in there. When we administered Penthrox, I forgot to mention it in the mechanism of action, is that after 6 to 8 puffs, you will start having, it will start working on the patient, and it will start feeling alleviation from pain. And obviously you need to instruct the patient that, sir, this is what's going to happen. You need to inhale and exhale continuously, and then once you feel the pain is relieved, you can start doing it intermittently. And it's a very potent pain relief, especially in the case of emergency, and especially when you said when you were doing that exercise in 2006, where they gave you that for pain relief as a simulation. But in real life, it actually works very well in managing pain when the patient is obviously he administered himself, he can follow instructions, his GCS 15, and he can administer himself. It's a very potent medication or drug to have in managing pain and assessing the pain. Not assessing the pain, managing the pain, and before you start with IVs and all the other things that comes along with it, or multinodal approach for pain management. So it's simple, it's easy, and it's quick to use it. That's what I wanted to add there,
Okay, thank you so much. Thank you. So we'll just move over to our next slide. It's a couple of pictures, it's actually just 3, and that will just give us picture number 1. That is the cartridge, the charcoal cartridge that gets connected to the top there. You'll actually just unscrew the bottom, and you can fill in the 3 mils of Penthrox or methoxyflurane. And third point, that's the patient needs to inhale. So what's actually so a lot of your manufacturing recommendation is that the person inhale and exhale through the inhaler, so that the activated charcoal can just catch, because remember, this is vapor.
Mr. Glenn, I think your network went again.
We lost him there. I'll just come in there quickly. It's a vapor, and if you can see on your screen where I use the cursor, right? So you can see there's a arrow going there, so you must like swirl it around to absorb the fluid in there. So like a sponge inside of this device. But what I wanted to say is to add onto it. On top here is also a hole where the filter is, and there's a nice video, but we couldn't play the video on here. So if you inhale, it comes in here and in here, and when the patient exhale, if you can follow the cursor, the air goes in and out of here. But when you want to increase your, like can I say, increase the dose that you want to give for the inhalation, you can actually close. You see, there's a hole there. You can actually close it all, and the patient can breathe in and breathe out, and that will increase the dose of the Penthrox that is being administered to the patient. And then to add to this, the smell of it's a very strong smell of Penthrox. So there's some recommendations when you mix it and when you set it up, you must be in a well ventilated area, because you as a practitioner can also inhale that vapor. And out of experience, I've inhaled it, and it can make you cough. It can irritate your upper respiratory tract. Over to you, Mr. Karolasan.
Well, that was my part. Actually, the next slide is yours as well. Thank you.
Okay. Let me just go to the next one. There you go. So overdose. So it's highly unlikely that you will get an overdose in the pre-hospital setting if we stick to the guidelines and the recommendations for what the manufacturer is saying for about 3 and 6 mils. And the moment the patient is going to overdose, it's when you're giving an anesthetic dose and you're going to have an anesthetic effect that occurs. So with the 3 mils and with the 6 mils, you're not going to reach that anesthetic dose for the patient. But obviously, with any medication, you need to know about the side effects or adverse effects when you administer this medication. And some literature, like we earlier mentioned, that patients, it depends on the threshold. They have what do you call this now? Index where, you know, this will work. Sometimes you must increase it, sometimes you must decrease it, the amount of medication. Where and Penthrox, obviously, if it's 3 mils, it's 3 mils, and that is a safe zone for patients to be administered. But if the patient overdose for whatever reason, the signs that the patient might have will be excessive drowsiness, including loss of consciousness. But that when you get loss of consciousness, that will be an anesthetic dose that you're already giving. There might be a drop in BP or respiratory depression, and if you look at the and then muscle, the muscle might maybe be polar, or there might be muscle relaxation. So the good thing of Penthrox is that when the patient overdose or the overdose on this, it resolves very quickly without any interventions at all. In my experience of using it for over 10 years, I haven't seen anybody overdose on Penthrox. And if even support, like it says in the literature that cardio and respiratory support may be implemented if needed. And I haven't seen any time when, in my experience, I'm not sure what Mr. Karolasan, but I haven't seen where I needed to have support for cardiorespiratory when using the dose in the recommended dose, that what the manufacturer is saying, of 3 to 6 mils and no more than 15 mils for a week. Mr. Karolasan?
Yes. So on your question, I've not seen the need for cardiorespiratory support in this case related to Penthrox. No, I haven't. I have not seen it.
So it's basically a very safe drug for any practitioner to use, and especially if you want a quick, non-invasive pain relief for the patient, to splint a leg, to do whatever. Penthrox is a very it's a very good adjunct to your drug bag to use in managing patients, and that's the excuse me quickly. Yeah. So, Mr. Kurwilson,
Okay,
we're
thank
going to
you.
take a
Yes.
5-minute break because the next slide is a case reflection. So
Case
we're going to
reflections,
take a
that's right.
5-minute break quickly. I didn't
I'll
take
be
it some
back in
water
5.
also.
Okay, all right. Be back in 5.
Okay,
guys,
that's good.
We will commence at
It's 6 o'clock, sir. 4 minutes.
6 o'clock, yes.
Yes. Just take a walk, stretch some legs, have some coffee, and then yeah.
Yeah, that's good. So can I send the test through then for the first 5 slides?
Yes. We can send a test through.
All right. So welcome back, everyone. So now we're gonna do some case reflections, where Mr. Cameron and Mr. Glenn is gonna share their experience and their case presentations as well. So yeah, let's go ahead.
All right. Okay. Thank you, everybody. So our first case will be mine. Case number 1. And we have, it's an 8-year-old male. He sustained a right wrist injury after falling from his skateboard. So in short, the patient's parents decided to take him to hospital and somehow make a rendezvous, a meeting point with the ambulance. Unfortunately, this meeting point happened on the hard shoulder of a very busy highway. And this is where the ambulance arrived about 5 minutes past 7. They, stop on the highway, have a look at the patient. Since the patient is able to walk, he got into the ambulance. And 3 minutes later, the paramedic or the advance unit arrived, patient's side. Okay. So from the current location to hospital is approximately 15 minutes. And if we just look at some examination things on the next slide, in brief, when you look at the examination, the patient had swelling, notable deformity with the vital signs, with a heart rate of 136. He had blood pressure of 100/60, GCS 15, respiratory rate 30, temperature 37. According to the patient, his pain score was 10 out of 10 and a severity. So let me just look at the sample, give you a sample history. So severity, it was quite severe pain. He does not have any allergies, does not take any medication, does not have only past history, surgical history, had a tonsillectomy. And that very morning, about 6:30, he had a glass of juice. All right. So this is our case in short. Mr. Elric, can you just maybe forward, then everyone can just see the screen with regards to the vital signs. Thank you so much. All right. So that is our case in short. So some of the issues that comes up, and perhaps maybe I don't know if our team would, our audience would like to engage with us. Let's talk. So, what are our concerns? What's treatment, and what are ethical concerns concerning this particular case? Anyone want to just give a comment, perhaps here at this moment from this specific case?
Can you go back to the slide again for the vital signs? The tonsillectomy, is that years ago, months ago, days ago?
So in this tonsillectomy, it was about 2 years ago. Sorry, I didn't put all that in there.
Thank you.
All right.
I'm just going to listen. There's just wanted to make you aware of. There's a question in the comments where they wanted to know what's the difference between Penthrox, the traditional Penthrox and Penthrox, and I just said we're going to answer that question within the one of the cases that we're going to reflecting on now.
Okay. All right. Okay. All right. So in this case, let me just give you a brief overview of what followed. So there's the option, obviously, we can site an IV line and start IV analgesia. And then obviously we have this fracture on the right wrist. We can stabilize that and monitor the patient and proceed to hospital. That's one option. Now, the option that was elected in this case, given the situation, so now, remember now, this has taken place on a highway, a very busy highway, and the shoulder was quite narrow. So your vehicle is half in the road. You're not really totally safe. So out of that safety aspect, the decision was to actually give the patient Penthrox, as this was now the quickest to get some form of analgesia, because to manipulate the hand was a little bit tricky at that stage. The patient was really not happy. If you had a fracture, it is it's a painful event, and I'm speaking now specifically in this case of the child. So instead of putting IV, we had Penthrox, put up to stabilize the wrist, proceed. And now once pain control was achieved, the IV line can come up. And since the time during the transport, further doses, you can continue now either with Penthrox or IV medications can come in now. Because now remember, once at hospital, patient will proceed, through X-rays and all that. So then by that time, your Penthrox is also finished. Now, safety was one aspect that needed to be addressed, and Penthrox was actually a very simple way of meeting the patient's clinical needs in this particular case. From an ethic point of view, and perhaps I can actually just open it to the point where it really depends what is your system. Maybe your system, you're not allowed to give, set up an IV. And let's look at the one side. Maybe perhaps you can put up an IV, but can it follow with IV medication? All right. And here's a very good case that, even though you cannot put up IV, you can still give analgesia. And this is the excellent place where methoxyflurane just fits in amazingly. What else does come out of this case? Now, since this is a minor, again, depending on what system you are, whatever age that is defined at. Now, since in this particular case, this patient was a minor, you can have, you need to interact with one of the majors, one of the parents or guardians for the permission of giving this medication. All right. And that is important because, like they say, if you haven't received, if you didn't get any consent and you touch the patient, it is almost like it's an assault. So also always bear in mind that we cannot force any treatment modality on a patient, and also likewise we need to respect the autonomy aspect of patients. So we act in to the benefit of the patient, but we also need to respect the person to have the power to make their own decisions and choices. Give them that autonomy and that level of justice that actually goes along with that particular situation. Now, the patient refuses to take any form of medication and treatment. Now, in your situation, your work environment, you will have a section that says refusal of treatment and or transport. And this is then very important where you start documenting the specifics. Now, the person might refuse a particular aspect of your treatment. Maybe they refused an IV line, as an example. But it does not mean they refuse anything else. Perhaps they accept the Penthrox. They accept that you'd want to do maybe a glucose test or any of the other things. And we still need to keep on treating the patient irrespective of whatever aspects they are refuse in terms of their treatment. So by signing the bottom line doesn't mean now you don't need to do anything for the rest of the trip to hospital, especially if the patient is not signing the refusal of transport. The patient still needs to receive, as we look at all the principles of ethics, the beneficence, autonomy, justice, non-maleficence, they still need to receive all of those things. So you as a practitioner need to maintain those principles throughout the rest of the case. And this all comes back to the point, now the word ethics in short, now it's got its root in Greek, and in the word there is ethika, and perhaps I'm not even pronouncing it right, but ethika actually refers to character. And we're not talking about the character of the patient or the character of the practitioner, but we're talking about the character of practice. And that's actually, the body of ethics speak about what is right and what is wrong. I don't know if there's any questions or something that someone would like to discuss at this point before we move on to the next case. Okay, I assume there's no hands. I don't see any hands. Mr. Ati, do you see any hands or anything in your chat on your side?
No, sir. No, sir. No hands. No comments.
Okay.
No
All right.
please.
All right. Okay. So now let's move on to our next case. All right. So our next case, 56-year-old male, and he's complaining of right-sided flank pain, and that started 2 hours ago, and the pain became progressively worse. When you examine him, he's got fever, and now it's not just flank pain, but also abdominal pain. So there's a radiate element that we spoke about earlier. It refers to his abdomen as well. Vital signs, 98 for heart rate, and the rest of the information you can just quickly have a look at that. So first thought was that this patient is having kidney stones. That was one of the comments that was passed on scene. But was it really kidney stones? Now, I remember a time where people were very hesitant to actually administer Penthrox because of kidney stones, because one of the contraindications referred to renal impairment, renal cases. Now, remember the whole aspect of nephrology. There are numerous diseases that one can find. So, in our specific case, after the assessment, this patient received his insulin. Now, one of his yes, sorry about that. It's just dropping here on my side. Hello, can you still hear me?
Yes, I can continue. You can still hear you.
Okay, sorry, it was just dropping on my side. Yeah, I thought there was just a miss. All right. So in short, then, now even though this patient is having right-sided flank pain, it turned out. Now I'm just moving a little bit forward, and from what his information is giving, he's got polycystic kidney disease. All right. Now, polycystic kidney disease, you have these cysts that grows actually on the kidneys, and they are extremely painful to the patient. All right. And they also, as you can see, the patient is known diabetic with hypertension. And in this case, now let's say he didn't have this diagnosis of polycystic disease. What else could tell us that, you know what, we can administer Penthrox? Now, back to the literature again, and literature speaks about basically they speak about the equivalent, the estimate glomerular filtration rates. And once that rate is below 45 mils, then they regard this as a, there's impairment of of his filtration. Now, we cannot really tell that in our ambulance. And this this is determined by a blood test. Now, perhaps if we one day lucky to have this thing, we will be able to know what is these glomerular filtration rates, and we're looking at patients with other renal problems. Now, the problem is if we only have one tool for a specific item or specific investigation, it's actually going to be very difficult to fit all our equipment in an ambulance, and very hard to even fit all your equipment into your jump bag, because you will be carrying so much things that I don't think we'll be able to respond to anyway. You probably have an ambulance with a trailer to get your patients around. And that is that one-track pony. We need to have something that's very diverse and that's very that's adaptable. And this is where Penthrox, I believe, is one of those medications that's suitable, as we've looked at the indications before, for various aspects, not just for a particular patient. And the concern that a lot of people had was renal cases. Now, I have seen persons in my practice, and I'm not sure if Mr. Aura have seen them, where persons with known renal problems received Penthrox and still walk out of hospital a few days later on. Now, there is one interesting aspect about methoxyflurane. So it does get metabolized in the liver and the kidneys. Now, given a couple of days, those metabolites break down the methoxyflurane, the medication in your body, and it becomes fluoride. And it's this fluoride aspect that is actually the damaging part to the kidneys. But this actually really becomes a problem, like I've mentioned earlier, if the patient really has sustained high doses or frequent use, using more than the 3 to 6 milliliters per day, or as the recommendation is 15 milliliters per week. I hope I didn't miss that now with the vials. Not 15 milliliters per week. All right. So this patient was successfully treated with methoxyflurane, Penthrox. Pain control was achieved. And now looking at things like flank abdominal pain and fever, these are closely associated with his underlying condition of polycystic kidney disease. And in many cases now, if we review many cases, none of them had adverse events or further adverse issues. Now, you need to really be aware when you do assess these patients to get as much information from them before you administer your medication. So make sure the patient meets indications, the various indication criteria, and the patient meets does not meet any contraindication criteria. I see a hand there.
Yes, sir. Can you hear me?
Yes, I can hear you.
Sorry to disturb. I hear you saying that the patient was treated successfully without any adverse event. However, my question now would be, if I had to come across such a patient with such issues, because I see there's a history there of kidney disease, there's hematuria there. I'm not sure what type of an antibiotic Ciprobe is, but just for the mere fact that it's an antibiotic of some sort, I would think twice about using the drug, even though this is not malignant hyperthermia or fever, but just for the mere fact that this medication has a potential for hyperthermia, already this will play me out of this equation. Now, my question now is, how would you have reached a decision that despite all of these things that I'm seeing here, I'm still going to give this patient this medication, if of course there are other options that you can explore?
Okay.
I'm making sense here.
Okay. All right. Okay. Okay. So here's the main thing about Penthrox. So I hear what you're saying. So you have limited information, but you have some information of the medication that you remember, that you meet the patient with. One of the big medications that an issue with these patients are nephrotoxic drugs. These are your tetracycline group of medications. They are actually they can cause, they have the potential harm of causing kidney problems, especially once you add additional Penthrox to this case. Now, but furthermore, a lot of research that has come out, and this is the one that has been hammered over and over, is if you keep within that low dose, 3 milliliters, that is 1 amp. If you keep within 3 milliliters to 6 milliliters, 1 to 2 amps, if you keep within that parameters, this is actually very safe, because they've done serum test. So basically, they've given some of these patients Penthrox, and and if they've done the controls, and to see how much this serum levels have increased, even though they've administered it, and it's still it's so low, and what they call it's not significant enough in these cases. Now, because the dosage is extremely low. I don't know if Mr. Aure would want to add something also here at this point.
Yeah, I hear the gentleman is saying that, if he doesn't know what medication the patient is using, I mean, that goes for any medication at the end of the day. That's why we do a sample history. What your past medical history, so what medication you're using, what you're using it for. And if you don't know what the medication is used for, you can always ask for the pamphlet, or just go on Google, what is this type of medication? And just to have a quick reference for you, because visual aid, especially in the practice we're doing, is very important. And that's what I would say is yes, you are concerned about this, and you don't know if you got it. Even if the patient doesn't know, it's the same thing when you ask the patient, do you have any allergies? And then the patient says no, but now you're giving a medication and then it's got allergic reaction, which means the patient didn't know about it, and obviously then you need to treat that in that regard. So once you rule out and done the due diligence of doing your sample history and saying, do you have any allergies? Are you allergic to any medication? Do you take any other medication? What type of medication it is, and all of that, which means you've done the due diligence before you administer the medication. Then I will say you on the safe side of doing that. But if you don't do any of that and just administer the medication, that is where the dilemma is going to come in regards to the question what the gentleman asked.
Okay. All right. Are you okay there, with sir? Is there anything else that you would like us to address more?
I gave you a thumbs up, said it's good. So you can continue, sir.
Okay, thank you so much. All right. So if there's any other questions in general pertaining to case number 2, then I will give over to Mr. Cameron to carry on the rest of the presentation.
Yeah, Mr. Karolisen, you can interject with me, or you can add comments. There's a question that, do we need an IV inserted before drug administration? Not sure exactly if it's for the Penthrox administration or for other drugs administration.
Okay. All right. Unfortunately, I cannot see all the comments that you guys are seeing on your side. So if you only giving Penthrox, and let's say your system, not your system, your current practice where you're working at does not require an IV, and you can proceed without an IV. Actually, you don't need an IV to administer Penthrox. What is actually more important is the monitoring of that patient, as opposed to the IV. Now, obviously, it also really depends on the clinical case. Remember, if this is a patient that would require fluids or some fluids or even IV medication, then yes, put up an IV. But in isolation, let's say this is a medical related case that the patient just needs some analgesia, then an IV is actually not the requirement. But if you can put up an IV, let's say you have backup that's coming, then by all means. But IV is not a requirement for the administration of this drug. Mr. Mayor?
It's probably not from me, but there's two questions that was asked earlier. One was from Dane. So he was asking about, it's a costly drug, and it's more expensive than getting ALS drugs. So that was the one thing, the statement. And then he also said, have you guys maybe looked at what the prices are and the costing? Because I know for a vial is probably about 700 Rand to get that, to get it in your bag. Do you perhaps know why is it expensive? Why is it so expensive? That was the one question. And then the next question was also asked. It was asked about, does it, I think one ask is to confirm, does it work the same as the discontinued traditional Penthrox? Do I take note of the packaging? Is it totally different because the person said Penthrox is a gas and this is a liquid form. So he just wanted to know that. Let me just tell you this, and you can see the question.
Okay. All right. So while you're setting up that, so that's the unfortunate part when it comes to what they call pharmacoeconomics, the manufacturing of medications, the licensing, the distribution of it, and so forth. So there are so many aspects related to this, which is actually way beyond our control. If I may make the example, for instance, with during COVID, we had the Johnson vaccine here, we had the factory, but even amongst themselves, the manufacturing thereof was. I don't know if you guys follow the story, but that itself was a lot of internal stuff about, can we manufacture it in South Africa or should it just come from abroad? Personally, and this is my feeling on this, you get the right ingredients, you set up a factory, you can make it locally. But now here's the thing, what's the cost of setting up factory? And you look at a lot of these car manufacturers, they do not just set up factory, and this is the same with our medication. Now, I cannot give you all the information as to why is it priced at this point. Now, and you're absolutely right, the price currently as it stands, you're looking at 700 to 800 Rand. Now, I can give you another example. What is this? EpiPen, basically containing epinephrine. Now, adrenaline. Adrenaline is also very inexpensive. And now the mere fact that it's placed into a wearable, in a syringe already, it also pushes the price to 1,000, 1,200, maybe more. So how that pharmacoeconomics work and all the pricing that goes into it, and I really think there's a lot of competition, a lot of regulation, and people that's just protecting, their recipes. Yes, I see the hand. I see a hand there, John Mayer and another
There's
person.
two hands. Can Mr. John continue?
Sorry, sir, you're not audible.
I hear that there is more of a logistical issue with regards to the drug. However, now my question would be, in a place like South Africa, why was it even considered for inclusion in our protocol if the logistic part of it would be the reason why we are depriving patients much needed pain medication, because the alleviation of pain is our core business on the road, and it should be accessible at all levels in any form that is possible. However, when you are a BLS or you are an ILS, you look like you are inadequate, whereas you are not really given all the tools of the trade to actually deliver. And for some, well, I wouldn't say for some, I would just say generally, it's unethical, and it's just that we are getting away with it because many people don't really know their rights to that extent. However, should others decide that they are acting on it now, it's going to be a problem for us on the road. How do we now protect ourselves against these logistical issues that are being raised by those who are supposed to be our managers or our bosses? This is where the problem comes with this drug. Can someone please assist us? Why was it included in our protocol in South Africa?
I'm sorry, I didn't get that question very clear. It seems like there's why some medication is in the protocol and some not. Mr. Cameron or Ati, you guys got the question?
So the gentleman can correct me if I heard him wrong, but I think the question is why was Penthrox included in the protocol? And then I think he also spoke about that other practitioners are not using it, and maybe it's because they don't know the drug. And then he was speaking about not treating pain management because of when you're not treating pain management, it's like unethical. So he was asking why was it included if maybe not all BLS or ILS providers, they're not going to be provided with this medication. So it could be an organizational type of a question, but I want to hear from you what you're going to say.
Oh, all right. Okay. So now this is a system question, and it's actually a very valid one. And what the budgeting is, and this is from what I assume that's the case. It's a budget constraint related situation for not having this medication on. And I do hear what you say. We need to treat pain. That's absolutely correct. We need to treat pain. And so basically we got this license or, scope to do certain things, but we are not provided all the tools. And this is where systems need to be optimized to actually be geared to fulfill this type of thing. Now, if you look at some private companies, they already have it. Because decision making is also so much quicker as opposed to a government system. And this has been my experience concerning this. If we have many stakeholders also sitting in the line as to, you know what, sign on the dotted line, let's place an order for this item or this medication, there's always going to be delays. I don't know what's Mr. Cameron's experience or perhaps his input on this matter, but surely the first point that I can think of is it's going to be a budgetary thing that will be placed onto the table. Fair enough. Also look at the current economic situation, and you can speak to any government department, whether it's education, healthcare. There are a lot of aspects now all being referred back to budgetary constraints. But now, interesting also, what I've seen in India, and I'm not sure if we have anyone from India here at the moment, and they can correct me if I'm wrong. They have humongous pharmaceutical companies, factories, if you will. And what I've seen in their setup is medicine are far cheaper as opposed to a country like ours. And if they can get it right, there's surely something that, our pharmaceutical companies can also do to get pricing down. It is ridiculous to see how cheap they actually can manufacture medication as opposed to ours.
All right. Is your question answered, sir? If not, we can give it to Mr. Cameron as well to answer for you, especially that he has some managerial experience as well. Okay, the gentleman said he's sorted. I see there's another hand raised there. The person can unmute and they can ask the question.
Hello. Good evening.
Hi there. Hello.
Good evening.
Okay, can you hear me? Yeah, just a comment. My name is Johannes Mokoena. I'm actually working for public service, but I'm actually currently a student as well, a CT student. I understand the issue of the cost of the medication, but I think it's something that we need in South Africa, in particular. And you would remember, if I just cite an example, the history of ARVs in South Africa. It all started very expensive, and as time went on, and people spoke about it, and it was part of the whole of discussion. The prices ultimately went down, and I think that if we also can canvass a lot, think about it, and advocate for our patients to get this medication cheaper, we can, in the long run, get it cheaper. One point that I also wanted to raise that about this medication. I mean, it's a very convenient medication. I was looking for a sporting activity where I think a well-known soccer player, I think you might also remember it. I think it's 2 months back, where this player was involved in an activity, and he had a fracture. From a distance, you could see that it was a bad fracture, and if my understanding was that if you had Penthrox at that particular time, if it wasn't administered, instead of you moving a patient out of the field of soccer, you could have given first the medication to control the pain of the patient easily, and you would have dealt with the pain of the patient at that time, and that would also have been an advantage of not delaying the continuation of the game at that time. So instead of putting up a drape or having to come, like you said about the equipment, having to come hauling down the Penthrox cylinder, which is also more expensive than actually this piece of medication. So that's my comment. So it's very convenient. We just need to, in the long run, deal with the pricing. Thank you.
Thank you, sir. That's noted. So now we're going to give it to Mr. Cameron to present his cases, and then he can present the first case. I'm just going to give you maybe 2 or 3 hands for question or comments, and then it goes to another case, and then after we discuss the other case. Thank you.
Thank you for that, Mr. Subada. Okay, guys, my case that I want to speak about is a plus-minus 6-year-old female patient who called for the ambulance plus-minus 3 to 4 times a day, complaining of pain. And I put there X, Y, and Z because whenever you go there, she will say it's my back pain. Then will say no, it's here in my flank, and then she will say it's somewhere else. So the pain always moves around, but she will sit down, she will talk to you. Patient was treated with Penthrox, right? So everything was done for the patient. Vital signs, patient is stable, all of those things. And then the patient will be treated with Penthrox. 30 minutes, hour later, she will say, no, I'm refusing transport, and resign the refusal. And that's went on for a couple of months. I can't even recall exactly for how long, until it was flagged, the case. As a patient, once the crew gets there, she will say directly, I want to have Penthrox. She will indicate that no other medication works for pain. So it's useless you're giving fentanyl, it's useless you're giving morphine, it's useless you're giving paracetamol, whatever medication there is, but she will tell you Penthrox works. Just to give a little bit of background of the patient was living on her own, no family around and all of that. So that's the social state of the patient. And as we investigate, look into this case further, that it looks like the patient is abusing the resources and there might be an element of drug addiction. And when I say abusing the resources, is phoning 4 to 6 times a day and holding up crews up to ILS level for 30 minutes to an hour. And then she will just say, no, the pain is fine, I don't need it, and refuse. And the only thing that after why it was flagged after a month was that she was I'll use the word clever. But what she did was she will phone at different times so that different crews can come and treat her. Which means if, like, I will give an example, there's 6 crews, A, B, C, D, E, and F. So crew A come treat her, so then that's fine. Later she phone another crew and a shift change again after the 12 hours she will phone again. So now this patient was receiving approximately every visit she will receive a Penthrox, 1, sometimes 2 doses, which means this overprescribed the recommended dose of 3 to 6 mils in a 24-hour period. So if you take 6 times 6, you got 36 mils in a 24-hour period, which overprescribed the double the dose for a week. And as it was flagged, because now she's calling and then the same crew goes back and she started mentioning them my name and talk with them. And then we realized that the problem here is the patient put herself at risk, number one, of using the medication so frequently. And because the crew doesn't know that the crew before that was there. And okay, you've got pain ma'am, yes, your pain medication. So especially in the context of Africa, it's going to be difficult to monitor if somebody is abusing this drug, because it gives you a euphoric effect also. It will be difficult because now you get Metro, you get all the different private services that has it. So they will call for this private service and maybe then that private service, and then they will refuse to go to hospital. And then they will call Metro and then they will refuse to go to hospital. So what is important here, especially with this case, is that when you do your sample history, so ma'am, how often does this pain, how often is the pain here? What were you doing the last time when you had this pain? And then generally the person will answer you and say, no, the other crew was here, they gave me that. But for some other reason, crews didn't pick it up that, okay, she got it from the other crew. Okay, and I'll just give it again because maybe they gave only one. So I'm going to give the next one, and that's a 24-hour period. And specifically with this case and the abuse of the medication and resources, it was more of a social state for this patient. It wasn't an economical thing. It wasn't any of that. What we discovered that when the cruise gets there, she will start talking with him and she will say, have a seat. Do you want coffee? Or do you want biscuits? She will speak to them for the whole 30 minutes to an hour, and then the crew will be gone. And especially in cases like this, when you go to a call and you assess a patient, it's important to pick up on these things that when last did this happen, ma'am? What did you do that time? Oh, there was another crew. What did they give you? You know, a little bit investigating what the previous crew did and when did this happen. And because he was, in my opinion, he was craving for interaction, social interaction with people. Because he also had condition of COPD and that. She was a little bit obese. And the important is here when we look at the ethics side of it, is that we're supposed to prevent harm or do no harm further. But in this special case, I will say, unknowingly, there was most probably harm done because she was getting up to 36 mils of Penthrox in a 24-hour period for more than 4 months. I don't know exactly how many months, but for months. And it says beneficence, we must supposed to do no, we must prevent harm. And if we only just tune in and investigate a little bit more on what happened, what brought the pain here, what did you do before, did you call the ambulance before, if you call us now, to get us to understand where the patient is, then we can intervene and say, ma'am, sorry, unfortunately, you did receive this that time, we can't give it to you again. Which was the case at the end of the day when it was flagged and it was investigated, that is what happened. But also in our context, that's where I was working, in our context, we need to refer this patient and getting involved other stakeholders. And when I mean other stakeholders, like send the patient on counseling or get a social worker involved to follow up on the patient. How's the patient's condition? If you remember when earlier in the earlier in the slideshow when Mr. Kadwasan was speaking about pain assessment and social and economical status, he was speaking about all of that, and that is what we need to explore in this type of patients, because at the end of the day, we will cause harm unknowingly, because the patient is literally abusing the system, and then she will refuse to go to hospital because my pain is gone. I don't need to go to hospital. The patients still have the autonomy that they need to exercise when it comes to the ethics. But now we need to tell the patient the truth of the medication and what it can do to them. Sorry. Now we come to justice. The patient says he's in pain, and earlier we said the pain it's perceived by the patient. If I say I've got pain, although my vital signs is normal, although there's no signs of, if you press or assess my pain, there's nothing. In my perception, I said I've got back pain, or it's chronic, or it's acute, I've got back pain. Or if I've got this pain, I've got wherever the pain is, then we assess it, we are supposed to manage it. But in managing this can also cause harm because the patient is literally overscribing the medication that is recommended, the dose that must be given. Is there any questions at this moment for this case? I see a hand there.
Oh, okay. I thought we were gonna finish and then we can give.
No, I can ask a question now. Sorry.
Okay. All right, you can ask the question.
Hi, good evening. I'm Berenice. I don't have a question. I just have like a comment. In cases like this, like say for instance, we are sent to a patient in that case. Sometimes we get familiar with the patients. So wouldn't it be advisable, like if I arrive at the house, patient ask for Penthrox, we administer or they take the Penthrox. So what, like it's like the same with patients that just require oxygen but don't want to go. But what we usually do is like we will if they refuse to go to hospital afterwards, like just inform them, look, if the pain is still gonna be there and we have to come back, we're gonna have to take you to hospital because it means whatever we're giving you at the moment is not working. Shouldn't that also be like an option, just to get them to go to hospital and not abuse the system or the medication?
Thank you, Berenice, for that. Yes, that was the case. The advice was, ma'am, let's go take you to hospital, but she always refuses. And obviously, there's the patient autonomy. I don't want to go. I can call you again. But now that's where the problem comes in. When she calls again, it's a different crew going and not the same crew. So there we need to track the patient once it's flagged. That's why I said it happened for quite some time, and then it was flagged. And then we looked into this. And then we saw, okay, now this is a problem. We need to address this problem. And it's number one, the system being abused. The medication is being abused. It's not good for her physically. It's not good for her body to have just amount of medication in a system at that rate what she was going. And that's when things were put into place for to minimize this, that get a social worker involved, refer the patient to things, and that improved the whole situation regarding this patient. And the key point that I want to direct to the audience is sometimes we just need to investigate a little bit more and think on our feet and listen to what the patient is saying and say, oh, so there was a crew. So why were they here? What did they give you? Like the other gentleman earlier said, when they use medication before you arrive there, what was given? And once you see something happening, like, oh, this patient is actually using it and so many times, obviously in your organization, you need to take this up the chain of command and say about quality assurance. Listen here, this patient is calling frequently. Is it something we can do? How do we approach this further down line? Because if this patient is carrying on in this trend, it's going to be harmful to the patient.
Yeah, so which means actually like the dispatch of the control, they also need to pick up like this address has been calling several times, but always the patient refused. So because like we've had cases like that where we get used to the addresses, like this, the crews will speak to each other again. So the control also they need to be. I know the dispatches they every time different dispatches, but I mean it also should be picked up by the control as well.
No, definitely that's important. If I mean where I work, that's why I'm saying it's a holistic approach. It's not just from the crew side in itself. It's from the call takers to the dispatchers to the other stakeholders like social workers, the hospitals. It's easy for the hospital to pick it up of what is given to the patient because the patient has a patient record. But for us, it's a little bit difficult. And now you get different services. So I'm not sure where you're working, but example, you're working at Metro.
Yes.
Metro will pick it up, but now the patient is calling Netcare or ER24 or other private service that has medication. And that's where we will have a challenge in addressing this. But that's where whenever you as a crew goes there and seeing this and it's flagged that is raised when what the patient is answering, that is when you need to investigate more and try to escalate this to up to the chain of command or to your quality assurance and say, listen, this is the situation. I'm not going to give this. This is the situation and understanding the drug. So if you know a crew before you was there and gave Penthrox, sorry, ma'am, I can't give you Penthrox, or sorry, sir, I can't do this because you're out of scope. I need to take you to hospital. But it's also dependent on if you are thinking on your feet and you're picking up what the patient is saying and doing the proper sample history.
Yeah,
thank you, Mr. Cameron, for that. Thank you for that, sir. I hope everyone had a question they got answered. If maybe you can continue with your another case. We have 5 minutes so that you can quickly wrap
yeah,
up.
Okay. I'll just quickly.
I think sorry.
Yes.
Sorry, Mr. Cameron. There's just 2 questions. I think we should take it, Mr. Griffiths. He's been. I think there's some good comment that he made in the feed.
Which one is this?
You can answer his. Mr. Griffin, one is He's got some good comments, but if he can just ask his question or
Okay,
make
yes.
his statement.
Correct. You can do. You can go ahead.
Thank you very much, sir. Yeah, I just want to comment on this case. When I was a first responder for some years ago, I had a similar incident, but that was not now Penthrox in question. But what I did after the third call that I received from this particular person, I called the medical officer and I said to accompany me to this person. Hello?
No, carry on. Sorry.
Okay. So I took the medical officer with me, and after explaining what I experienced the three times that I visited this patient, he told us straight, listen, if you don't come tomorrow to see me at my office, I bring the police the next time to your home, because you are abusing my system, you are abusing my resources, and you are abusing drugs. So the next morning, she was sitting in front of his consultation room. So yeah, it's difficult to pick it up if there are different service providers or different crews. It's difficult to pick those things up. But I think people will abuse us as EMS crews and personnel when it comes to these pain-stilling drugs and etc. Thank you.
Thank you, Alexa. That's very true what you're saying there, and that's why I'm hammering on that we as crews need to be very vigilant and on guard when patient is answering or saying things. As if you look at what I said, the patient started asking directly for Penthrox, and basically when somebody asks for not just Penthrox but for any other drug, then you need to know this might be a problem that we have on our hands with this patient, and the patient might abuse the substance. I'm just quickly it's very similar. The second case, where there was a male patient complaining of back pain. His vital sign was always normal when they get there. The full history, his past medical history, he's got back pain. But with this one, every time will go to different locations to phone for an ambulance, so that you don't pick up that it's the same patient. And that can be another problem. And then the other thing is, because when you if you abuse substances, you're thinking out of the box, to put it that way, to get what you want. And you always get the maximum dose. But the other one here is, this patient told the crews in itself, listen here, I'll give you money so that I can take this medication at home and I don't need to call you. And that is a big ethical thing that the crews need to look at. It's like you want to bribe the crews to get the Penthrox, and that is very concerning, because some crews will say, "Oh, I need some extra cash. Okay, here's a vial of Penthrox for you." And then when we cross the line of doing for no more harm, about justice and all of that. So as crews, we need to understand that when we give the medication, we can't just tell it to people, because we need to administer it to them. The other thing that I want to bring, there was a question about, because I know we're running out of time, I just want to answer the question about Penthrox and Penthrox. It's basically very similar. The difference with Penthrox is you need to have a bottle with the high pressure hose, the valve, the mask. The patient is taking it, but it's very difficult to monitor Penthrox. How much did you give for this patient? How much did you give for that patient? Whereas with Penthrox, and that's where the drug record keeping, it's on the slide that I'm saying about drug record keeping is very important, where the Penthrox is for a single patient, 1 use only, and it's done. Whereas Penthrox, you put it on, example, I mean, when I was in service, I know about the Penthrox, and sometimes I will use Penthrox, and I was using Penthrox, and then not I was using Penthrox, but you can use Penthrox, Synophyt. Oh, this is the effect you get in. I wasn't abusing the Penthrox, but what happens is I'm using it, for example, I've got pain and I'm using it for half an hour or for an hour, but I'm using it continuously so I can empty the whole bottle, whereas Penthrox gives you that full indication of where it is and how it is. And it's very easy to use. There's less parts and mechanisms that you need to take with to the patient. It's just a vial in the drug bag and there you go. So I hope I answered that other person's question when it comes to the difference between Penthrox and Penthrox. So I know this is not a scheduled drug for double lock and key, but good record keeping is very important for Penthrox. And the misuse of Penthrox for this drug is it can easily happen, public or staff. And therefore, you need to, whichever institution you're working in, must have a good record keeping of it. Example, 2 Penthrox per crew. Just as an example, every institution must obviously decide on how they're going to manage it. Patient record and incident number must be signed, and when you replace it, you must give all of those details that I've used on this patient and all of that. If it breaks by accident, then you must report it, bring back the broken ampoule, but also bring back a clean inhaler. So then you can see, okay, the screw wasn't abusing it, but it did accidentally broke. And that is the just key things that we need to consider when using the drug and on the patients and in the public. Is there any questions? I see a hand, Mr. Mayor.
Yeah, all right, Mr. Cameron. I don't want to cut you off there because you're sending some very, very important information. So, Mr. Mayor, we're off time now, like 2 minutes late. I want to apologize to the people because it's case reflection. So I must allow people to reflect on themselves, but cases. I'm going to give you, sir, the opportunity to speak, and then we can take it from there.
I think it's more a question than a statement. I think for me the question is with this Penthrox as a Schedule 5, how do we inform patients? When we give, do they need to go to hospital or do we just give it and then leave them at home? Is it one of those things that we can just pre-hospitally discharge, or we going to encourage them to stay home if it's just a back pain and then the pain is relieved? Do we advise them to stay home, or do we advise them to go to hospital? And what is our thoughts on that? Okay.
If I may answer that, I would say that's on case dependent. So if it's chronic pain, different story. If it's acute pain, the patient must obviously go to hospital to see to the pain or the injury or whatever happened. So the reason for my 2 cases, if you look at Mr. Karol's cases, it was acute injuries, patient needed to go to hospital for further management and treatment. Whereas my cases was more of abuse of the system and of the medication. And once that is happening, that's where the concern comes in. I mean, it's a nice drug to use. It's very good. Everybody can use it from BLS to ILS. It's very quick to use. It's easy to use. It's not invasive. But when it comes to the patient, it's always advisable to send the patient to hospital, let him go to hospital so that he can see why is this pain reoccurring, or what did he do, or any of that. But if you pick it up that the patient is every time calling for the same thing and it's over and over and he didn't go to hospital, then I will advise that he needs to go to hospital and need to seek. You need to get other stakeholders involved in treating the patient.
All right. I think you must also look at the direction or the angle of it. Maybe BLS crew now with Penthrox. They gave the medication at the time. So the patient says now the pain is all right, it's 0, maybe it's 1. Do you think it's best for them to leave the patient, or they must consult for an ALS practitioner to advise on the case if the patient says, no, I don't want to go anymore? So maybe that's another question maybe Mr. Mayor was asking.
Okay, so the thing is, if BLS is unseen, I mean, obviously the patient has autonomy and the patient can refuse. But I mean, we as crews need to advise and give full advice to the patient to say, sir, yes, we've treated your pain now, but we don't know where your pain is coming from. Why are you having this reoccurring pain? I will advise that you need to go to hospital so that they can see the source or where the pain comes from. Because you're going to phone us back again and we're going to come back for you, but then we're going to need to take you to hospital because we can't give you more of this. And therefore, when I was saying earlier about when you see as a reoccurrence of this address, especially in the South African text, some people know, oh, we're coming back to that address again. Then you need to start getting other stakeholders involved to see if it's a social issue, if it's an economical issue, why is this patient calling again? He needs to go to hospital again. Let me take him to hospital, but not give him that medication because he can become addictive to it.
All right. Thank you, sir. My
I see
sister
Mr.
had
Mayer is there again.
I think he forgot to drop it down.
Okay.
Mr. Mayor, you have a question?
Samson has a question there. A hand up.
If Mr. Sampson can speak.
Okay, thank you very much for giving me that opportunity. I just wanted to ask about in a case where some people abuse this medication, what precautions or if I can say, what harm can it cause? Because I think one of the overdoses is drowsiness and unconsciousness, or is it a coma or unconsciousness? And what precautions, what advices should we give to this kind of patients that, okay, if you are overdosing this medication or abusing it, this is the damage that it can cause in your body?
So okay, I will. So I'm gonna use like example paracetamol. A lot of paracetamol is actually a very dangerous medication if you overdose on it, because it will affect your liver and it will damage your liver down the line. If people overdose on paracetamol, is very dangerous. But people don't know that. The general public don't know it because it's a medication I can buy over the counter. With Penthrox, I think the main concern with Penthrox is your kidneys. It can damage your kidneys, and your kidneys is very important to flush out toxins and all of that. So that is what the patient needs to understand. If you misuse this, with any medication you misuse or abuse, there will be consequences and there will be a effect on your body. It might be your kidneys, might be your liver, whichever part of your body that's going to be affected, it will affect you. And that is what that's what you need to relate to the patient, to say, if you abuse it, this is what's going to happen. And it's not nice not to have your kidneys working properly, to go for dialysis or whatever the case is.
All right. Thank you.
All right. Thank you, Mr. Cameron. I hope there's no other question or comment. I can allow one comment, no question. Oh, unless there's a question, because we're almost like 10 minutes over time.
John, Mr. Mayor? Mr. Mayor, your hand is up.
Yeah, I think it's just for everyone. So from our side, from the university side in Cape Town, we will be hosting a hands-on session. We will host quite a few just on this medication itself, how to use it, the how-to session, the hands-on session. So Mr. Ati will then share another link in due time. We will open up just a register who wants to attend the hands-on session at the university. Currently is in the university, and then we might have something in the Eden district setting up where Mr. Glenhill will also host a session, a hands-on session for Penthrox administration, and getting that signed off as a hands-on, because the theory, the didactic portion of it is not sufficient enough. You still need to have the hands-on and then have the talking sessions around it, ask the questions that you couldn't answer. So yeah, so keep a lookout for Ati's post, and then he will update for those sessions, the hands-on sessions, whoever wants to attend those sessions. Thank you.
All right, thank you, Mr. Mayor. That was going to be my closing announcement, but thank you. Yes, sir, Mr. Cameron Ken.
I just want to thank everybody for participating. I just want to thank everybody. Thank you.
All right, thank you, Mr. Cameron. Mr. Glenn, do you want to say something?
Well, it's been a privilege to be with everybody, and it was very nice and engaging. And actually, Mr. John, that session is probably 99.9% ready. The hands-on session, that's like a follow-up to this activity. But thank you, everyone.
All right. So from my side, I'd love to thank you both, Mr. Cameron and Mr. Glenn, for sharing that experience. I myself only used it once on a patient, so I learned a lot in this case. So I thank you so much for availing your time, and especially this time when you're already coming from work, you're tired, and then you take a time from your kids' time to present this case for us. And then I'd love to thank all the participants, the guests, people from different provinces that attended this session with us, and then they also shared their stories, and then they reflected also their cases. From myself, I say thank you. Bye.
Mr. Artie, come to the practical session.
Thank you, everyone. Enjoy your evening further.
All right, keep well. Thank you.